All right. Yeah. Ready to get started?
Yeah, let's do it. I mean, if anything goes terribly wrong, you can always just edit it, right?
Yeah, I can.
So,
Yeah. No, I
okay,
definitely have certainly have done that in the past. Yeah.
awesome.
Man, some guests, you wouldn't believe the things they nitpick.
Oh, I'm not nitpicky at all. Uh,
It's okay if you are. I understand. I mean,
we're all
peop
humans, and I'm an orthodontist, right? I'm not supposed to be good at like podcasts or talking or whatever. So if I
yeah.
slip up, it's okay. It
Yeah.
happens.
Yeah, yeah, that's kind of how I feel too. No, believe it or not, there's like in my neck of the woods, which is like the
Yeah,
patient advocacy space, people like the doctors that don't necessarily present that well and that seem to not care that much about social media
yeah,
because there's becoming an association with like so-called social media orthodontists and social media surgeons.
yeah. I
And
agree.
it's a little bit of a negative connotation.
Yeah. So like when I first started out, I was doing like all the trends and all the dancing because I was just trying to like make a name for myself, and I got no patience because I think I was like very disingenuous. Like that's not really who I am. I'm a terrible dancer. Um, and it was like it was so much effort for me to do these videos, right? And so then like a year and a half ago, I just started posting whatever. I literally just I'll just like screen record my finger like pointing to stuff. I don't edit it. I don't even look at it, and I post it, and it's been doing well.
Yeah.
So
Yeah, authenticity is gold. People
100%,
have a really good sense for what's real and what's not.
definitely. Unless you're in like Hollywood, LA, or Miami, then you know.
Yeah. Yeah, 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 I guess so. I guess so. I feel like um I feel like we've gotten to the point where it's almost come full circle where people don't want the polished, people don't want the highly edited, people just want a real human being on the other end.
Yeah,
Especially now in the era of AI, there's an even higher premium for authentic human creation. And so, in a way, it's lowered the stakes because
yeah,
typos just mean you're not using AI. And like a few extra ums and ahs means that you're not trying to polish something to try to sell anyone anything, right? You don't have a
yeah,
high budget in post to
yeah.
create this, production to sell something or other. So it's good. It's I think it's a healthy thing.
100%. And it's like I feel like now too, I see a lot of creators, business owners, they're just like, they're starting out. They have like a pizza stop or pizza shop, or they have like a clothing brand, and they just like show all the steps from A to B, and it's just them talking. And I think that those people are doing really well now too.
Yeah.
So
Yeah, yeah, yeah. Yeah. So I know you have a big TikTok channel, a big Instagram channel. I see recently that you just ventured onto to YouTube. So, as an orthodontist, what
yeah.
brought you to the social media space? Is it essentially just your marketing wing of your business since you're a small business owner? Is this something that
Um,
gets talked about in dental school now? I mean, when did you complete your
yeah.
orthodontic residency? Like how far out from dental education are you at this point?
Yeah, so I graduated ortho residency in 2020. So I'm like 6 years out. Yeah, exactly. Actually, today is exactly 6 years
Wow,
because
congratulations.
you graduate, June 30th, and you start July 1st. Um, so I started it because my co-resident, Mikey Golub, was like, you got to get on TikTok. Like, let's just make some stupid videos. And so if you scroll back like way on my TikTok, it's just me like, I'm like, oh, like these are the cool colors of the day. Or like, it's just like us using different trending sounds and making like, stupid stuff.
Yeah.
Um, and some of them it was like right when TikTok was this was before COVID, right? So 2018, and this was like you could just post some random thing and you get millions of views on a TikTok. So some of them like did crazy well. But I didn't get any patients from it. I was just like a resident. And then I started my real job, and I stopped posting really. I did like here and there. I was just an associate working for someone, and so it's it's hard to it's hard to like post on TikTok or social media like when you work for someone else. right?
Because you don't want to be cringe under their brand.
Yeah, you're representing them. And
Mm.
so,
Did you ever work in Boston? Because I saw you did orthodontics in Tufts.
yeah, I did Tufts orthodontics. I never worked in Boston.
Yeah.
And I remember, sorry to go off track. Did you go to Tufts? Like, did you get accepted to Tufts? Like, what's your connection to Tufts?
I did the Tufts post-bac pre-med program with the intention to go to dental school. And when
Okay.
I applied to the Tufts post-bac pre-med program, I did a dual application to
Yeah.
the Tufts dental school. So you can do a linkage application
Okay.
where you apply for both simultaneously before you even begin the post-bac pre-med program.
Okay.
And so I went into Tufts. I interviewed with Dean Holloway there.
Wow.
I did a tour, et cetera, was accepted to both. It's a conditional acceptance, meaning you have to succeed in the post-bac pre-med program, which is a brutal program. You have to get a certain baseline score on your DAT. I never took the DAT, so I guess you could say technically I didn't meet the conditions. However, it was mine to lose.
Got it. Okay, because when I started out in ortho residency, I actually remember seeing you. Like you had popped up somewhere, and like between the residents, we were like, "Whoa, like, this is crazy!" Like this guy just like put a palate expander in himself because they weren't really teaching us like adult maxillary expansion. That's all I remember. I don't remember the details.
Oh, no kidding. Well, we were at Tufts at the same time. So you were there from 2016 to 2020.
I was there 2018 to 2020.
Oh, 2018. It's a 2-year residency.
Yeah, and I did dental school 2014 to 2018 at Stony Brook.
Roger. Yeah, so I was at Tufts 2018 to 2020 as well.
Maybe, who knows? Maybe we talked to each other.
Well, I was not at the dental school. I was not in Boston. I was in Medford at the undergrad campus.
Oh, then zero chance.
Yeah, but you were probably getting ready to start like when I was doing my interview and stuff at the dental school.
Wow,
so
crazy.
Yeah, small world. Yeah, but so I'm curious. So now you do lots of airway stuff, and by that I basically mean skeletal expanders and airway considerate orthodontic treatment, where you make things bigger when they're crowded rather than remove teeth and shrink them down to the arch that's there. How did you get into that? Is that something that you learned at Tufts? I'm not aware of any specifically airway-centric people at Tufts. I know at BU there was Dr. John Walker, who was kind of an airway pioneer. At Tufts, I don't really know anyone. So how did you get into it? Did you break from your traditional training at Tufts, or was it something that you actually were introduced to at Tufts?
I felt like we actually got good information on everything. And my program director at the time, Dr. A, he actually lectures a lot about MARPE treatment, and he's like doing a lot of that work to advance it. And so maybe he doesn't call himself like, an airway orthodontist. I honestly don't even call myself like an airway orthodontist because that's like not an official term, right?
Correct.
It's kind of like a made up term, but I always think about the airway, sleep, breathing, all that stuff. It's really important. And I recommend MARPE or MAPE or whatever. I'll recommend that, and I'll recommend orthognathic surgery as well. And so we definitely did a lot of work that would be considered airway centered, airway orthodontics. We might not have put a name to it, and maybe he's not like in like the airway circuit or whatever, but you can look up his articles, right? You can look up his lectures. He does a lot of MARPE and that type of treatment.
What is he using? Is he using MSE? Is he like a Juan Moon kind of guy, or is he doing custom MARPEs, or is he doing SARPEs?
When we were in school, it was MSE, but that was right. That was 2018 to 2020. So was custom even there?
No.
Yeah.
No, it wasn't. It was all MSE at that point.
Yeah. So it's funny, right? Like people always say, "Oh, like can't believe you had an MSD," right? That's what was there, right? Can't believe you had, banded MARPE. That's what was there. So I can't believe you had SARPE. Like this is just like an evolution of time. And so when you're talking about stuff pre-2020, even pre-2021, 2022, like we didn't know, right? Everyone was just doing their best. figuring it out, and we're still figuring it out. And there's still people are still publishing and researching and all this stuff.
Yeah.
So yeah, to answer your question, I don't think I really veered off the path. I just kind of like took the tools I had, and I've just tried to like make good decisions. Now, the reason I really got into it was because my friend from college, his name's Mark, and he was like very involved in these Reddit groups. And he was sending me all this information. And he actually ended up getting E's with Casey Lee. And I was really like helping like coach him through that and figuring out like, what's BS and what's real in this, in these Reddit posts, like what's actually backed by science, what's research based, and what's just like, who knows?
Mm-hmm.
And he's like he's really, really smart. He's one of these guys that, he like, what do you guys say? Like you hack the CPAP, right?
Mm-hmm.
Um,
Mm-hmm.
and he, talks to like cardiologists and allergists, and he probably knows more than most dentists.
He's a layperson.
He's a layperson. He's like
just
in
a patient.
tech business. Yeah, he's a patient. He's a friend, but he really understands this.
Mm-hmm. Mm-hmm.
And so that's where I really got into it, and everything he was saying to me was making sense. And so I didn't learn like in dental school, right? They didn't teach us about we didn't learn about CPAP, right? We didn't learn about Inspire. We didn't learn about all these other things out there. We didn't learn. It was 2018, so we didn't really talk about dome or anything like that. It was really SARPy at that time.
And when you say dome, you mean like a heavily surgically assisted skeletal expander?
Yeah.
Because of course now dome that term has been commandeered by the dome MASPE thing.
Yeah, that's
which is
smart.
like, come on, of all of the potential acronyms, like there's literally an infinite number of potential acronyms that could have been assigned to that specific like marketing of a type of MARPE process. You had to use an acronym that was already associated with a different MARPE thing that's a totally different category of treatment, which is like an obsolete massive surgical assist with Lefort cuts and whatnot. And now it's like, I have people commenting on my videos, what do you think about dome? And I'm like, well, which dome are we talking about now?
Yeah. Well, just one thing. I don't know if it's completely obsolete.
Okay,
fair enough. It depends like what are you saying dome is. But I know there's people that say you can expand everyone without doing any cuts, like even piezo cuts. There's people I don't know. I don't like to ever say like something is like obsolete or not usable, because there are people with like very complex anatomies and whatnot, and it could make things easier. I guess you could say SARPy is obsolete, and by SARPy I mean doing those cuts with a tooth-borne device. It doesn't really make sense to me. Like, why would you do that except for insurance reasons? But yeah, to go back to your point for the dome, I understand why they're calling it dome, because like Stanley Liu made it and that's his thing, is dome. So I guess he can take that name. But I agree, it is confusing. It's very confusing. And I also understand like a dome means like a dome arch, right? So that's kind of what they're referring to.
Are we talking about the new Dome Zero thing?
Yeah, the Dome Zero thing, yeah.
But does the Dome Zero thing does not actually include Dr. Stanley Liu's like surgical assist at the back end? It's just, I don't know. It's just it's an armless custom MARPE with a no diastema protocol and Invisalign treatment mixed in. There's no actual surgical assist, right?
They use Spark actually, but yeah, I don't think there's a surgical assist. I'm not sure, but I know Stanley's involved in Claudia Pinter. And
Dr. Stanley Liu's involved in the Dome Zero thing?
Yeah, of course. That's why it's called Dome Zero.
Oh, tell me more. I guess I don't know enough about it then. I mean, so it's
okay. I mean, okay,
because I thought Dome originally referred to Stanley Liu's surgical assist.
So Dome, exactly. Dome developed it with Audrey Yuen and other people at Stanford. and that was the cuts,
Correct.
right? The
Correct.
surgical cuts, which was like revolutionary at the time, right? Like no one had ever done that, and no one had ever seen airway improvements with that done and had done that research. So that's awesome. But now Stanley, Dr. Liu, Dr. Pinter, and this guy, Dr. Adams, have like joined forces to make Dome Zero. I honestly don't know much about it. The only reason I know a little bit is because when it was called MASPE Zero, I was like one of the original people on it. Basically, like me and this guy, Dr. Adams, we like bantered online on TikTok, and then he asked me to like be a part of it. So I said sure, and then I was like the next moment I knew it, I was on his website, like my face, like an AI face of me and my information. I was like, okay, like I'm like pretty chill. I'm like sure. I hadn't like signed anything or whatnot. And basically he said you just have to uh like we're gonna give you patients, and if they come through us, then you have to like use our lab to order the appliance. So I said sure. Um, but then they switched to Dome Zero from MASPE Zero, and then I was asked not to join. So
Yeah,
I'm no
interesting.
longer a part of it.
So, is there anything about that brand of MARPE treatment that's actually special or different than like a well done custom MARPE from partners or an FME, or is it really just a marketing package? And I don't mean, and I'm
Yeah.
not trying to goad you into
Yeah.
disparaging it. I'm just trying to
Yeah.
understand. This is my channel is a very technical channel, so I
Right.
like to draw technical distinctions. Like,
Yeah.
okay, are the TADs different? Do they have certain patents around like their jack screw? Is it,
There's no patents. I would say it is a process that they've had success with, and now they are teaching other orthodontists and dentists how to do it. And I guess there's like a what's the word? Uh, Not protocol. I mean, there's protocol, but there's like checks and balances, right? So like if you do it through them, then it's like approved by them. Um, which I get because I don't know if you've seen, like if you've ever had to design a custom MARPE, um, there's a lot of differences in opinions, right? uh, TAD
like,
placement, tricortical, bicortical, monocortical, intraradicular, mid-palatal, number of TADs. Like there's a lot of different philosophies out there, and people will say, I think this is the best, right? But there's actually no research to tell us what the best is, right? We're kind of just going based off of people's experiences and whatnot. Eventually we'll have that. Um, but no one has published a large randomized clinical trial to actually tell us, right, what is the best.
yeah,
So,
yeah.
um,
We
but
can
yeah,
use common sense to take us so far in that, in answering that question. Like, objectively speaking, there's probably, for example, not to take this immediately to FME, but like,
yeah,
I I'm of the opinion that connecting to teeth is a necessary evil at best, because it just essentially means that the appliance with TAD anchorage only, without additional dental anchorage, isn't sufficiently strong to break the suture and expand. And so you need to connect to the teeth to give it a little bit more strength. But that can only lead to complications in terms of a certain amount of expansion going into the dental alveolar expansion rather than the skeletal expansion, patient discomfort,
hmm.
etc.
Like if we think theoretically, do we want to put expanders on teeth? No, right? If we have enough bone, thick bone, why would we want to put an expander on teeth? Does it make the process easier because like we're just kind of used to it, right? Like because when you ban the appliance, now you have exactly where the tag goes, and you just put it in. It's definitely like a much quicker process, I would say. And then there's more like failure. What's the word? More like failure safe. Like let's say a TAD fails or something, at least you have it bonded to a tooth and stuff like that. But I would say, yeah, in an ideal world, we wouldn't want to have it bonded to teeth.
Right.
Um, but we're all humans and nothing's ideal.
Right. Right.
So
But I'm in the business of like at least trying to understand theoretically what's best, even in the
yeah,
absence of clinical trials. Another distinction that we could draw we could talk about anterior preference versus posterior preference in the placement of an appliance. Like
yeah.
you could put a custom MARPE way up front where the bone is thick and you can definitely split the suture there, but then the type of expansion you're going to get might be more conical
Yeah.
or Pac-Man shaped. And maybe we don't have the studies that show, okay, maybe that's not as beneficial to nasal breathing as compared to a more posterior bias in the placement. But we can still infer that using common sense or just basic anatomical understanding. What are your thoughts on that?
I would say this reminds me of like the implants debate. So back in the day, uh, you would have like an oral surgeon place an implant, and they would just do it based off of the bone quality, right? Where's the thickest bone? But if you do that, then you could have an implant in a really bad spot. Like now, aesthetically, it's really difficult to restore it because it could be like very far buccal or very far lingual, and so then the tooth would just look weird, right? And so it's kind of reminding me of that. Right? Is it what's more important, having good bone or having it in the right place, and then kind of uh, compensating for that by doing different cuts and whatnot to help us.
Yeah.
And it's as I said, theoretically, yeah, you want to put everything posterior as possible. You want it in good bone. You want all these different things. But when you get to actual patients, actual individualized care, you can't just have like a hard and fast rule.
No, of
And
course.
and that's why this stuff is so difficult. And I feel like I get so many like messages online, like, oh, like, do I need MARPE? Do I need Invisalign? Do I need this? I can never answer those questions just based off of text because you always have to look at the X-rays, CBCT, photos to individualize the care for that patient. So it's tough.
Yeah. So
It's
what?
tough.
So then, where does that leave you in terms of what tools you're using in the job?
Yeah.
Are you using a variety of different tools when it comes to expanders? Are you?
Yeah, so I haven't done an FME yet, but I'm going to. And I was honestly hesitant at first because I felt like it was very similar to the MSE, right? Like a non-custom appliance that you're just kind of putting in the palate. But now like I spoke to the people at FME and I kind of understand. I've watched a lot of Dr. Manueli's videos. He even put it on himself, right? I'm like, okay, I must be missing something. There's something there because I really respect Dr. Manueli. Um, he's a great lecturer and like such a smart guy. I'm like, okay, what am I missing? And so now I get it, right? There's a lot of things that the FME can do, honestly, more so for the practitioner, right? For the provider. It makes our lives easier for certain things. And so I get it. And so I'm interested in doing that if the patient's a candidate, right? Some basic things. Why would they not be a candidate if the palate's too narrow and you can't even get the FME in?
Yeah.
That's an issue. If you don't have enough bone, right? That's another issue.
And by that you mean just a really thin palate?
Yeah. I mean, maybe you're not. If it's really thin, maybe you're not even a candidate for expansion at all, right? You have to weigh the risks and balances.
But with patients with really thin bone, you just go to the more transverse TADs in a custom MARPE. Is that right?
Exactly, something like that.
Yeah, and dental anchorage.
Yeah, but then you got to think too, right? Like, I always have to think about the patient. Like, if they don't have nasal breathing issues, right? If their width is pretty good and they still want MARPE, maybe, and they really have like airway sleep issues, maybe the issue is they actually need orthognathic surgery, right? And so you have to start thinking about risk benefit. Is the MARPE really worth it? Or should we really be thinking about orthognathic surgery? Because we could accomplish a lot of that stuff too. So yeah, that's why everything is, uh, it's hard to assess.
Mm.
Um,
Yeah, it's very individualized. Is that what you
but
mean?
yeah, but I do imagine a future where we can take a CBCT, AI can diagnose the bone quality, like kind of it'll like automatically kind of put all the tabs everywhere, seeing where is best, and then it could like give us a prediction of like what would happen if we expand, right? How much could we expand and all that stuff.
Mm.
Uh,
Mm.
I give it a few years at least.
And do you think it'll be able to tell you what the patient will look like as well with a certain amount of expansion? I know there's a lot of question around the relationship between expanders and
Yeah.
cosmesis. It's a kind of a controversial topic. I've been very
What
critical.
cosmesis?
Yeah, just like how someone looks after. Are they aesthetic?
Yeah.
Or does it improve the way you look? Does it detract from the way you look? And does it depend
Yeah.
on the type of expansion, the quality of expansion, the magnitude of expansion? Is there a way of knowing beforehand which types of patients will look better versus which types of patients will look worse? Is it
Yeah.
really an appropriate treatment for someone who's looks maxing at all? Or is it
Yeah.
really a looks minning treatment? I mean, it's complicated. Very
Yeah.
individualized, I would say.
I,
What would you say?
I would say if you're doing it just for aesthetics and there's no underlying skeletal discrepancy, I do not recommend MARPE. Right?
Well, by definition, if there's no underlying skeletal discrepancy, then of course not, because then they would just be blowing their upper out of proportion.
Correct.
So
Yeah.
you're saying for patients that would stand to gain functionally, they may stand to gain cosmetically, but it never is kind of one but not the other. Or it's never
Correct.
aesthetics only without function, because
Yeah.
the patients that benefit aesthetically by definition have narrow palates.
Yeah. But I will say most aesthetic issues, most of those people do have narrow palates or sleep issues, airway issues, recessed maxilla, mandible. They usually come hand in hand. But
Yeah.
you get the occasional patient where there's nothing wrong with them and they really need to see more of like a psychologist or something.
Yeah. Do you see a lot of that?
No, not that much.
Yeah.
It's rare.
Mm.
But I'd say that it can happen. And the other thing that happens too, I think people that have migraines and they think it's like TMJ pain, and then they think like the MARPE will fix it. I'm hesitant to treat those people as well.
Specifically headache patients?
Yeah, people not if people have headaches or like TMJ pain and there's no like crazy skeletal issue, I can be hesitant to treat them. Because I've just seen cases from other providers where they've been told MARPE jaw surgery will help them, and it never did. I mean, they look better, right? They have wider teeth, or they have a better bite, but they still have the chief complaint, which is the pain, right?
Yeah. Headaches are complicated. That's what brought me to all of this was headaches.
Oh, really?
Yeah.
And did it help?
In some ways it did, and in some ways the underlying condition is definitely still present.
Exactly.
I mean, in my case is a little bit. And headaches, I think, are also, there's not one type of headache that everyone suffers from. There are
Have you ever seen a headache specialist?
several. Yeah,
Several.
several.
Like they're boarded by a headache.
Yes.
Okay.
Yes. Several neurologists, and then with that specialized in headaches, and then as well,
Yeah,
a headache surgeon. A headache surgeon.
Okay.
Yeah.
I didn't know this, but there's like a headache specialty. You don't have to be a neurologist. You could be an internal medicine doctor, or whatever. But they treat migraines and whatnot, and it's tough, right? There's nothing. They don't know that much about it. So would you say the MARPE helped a little bit with it?
Yeah, it did help a little bit. It helped
Okay.
significantly.
Oh, okay. Good.
And I think specifically the way that it helped mechanistically is by sort of relieving my neck posture, kind of giving me more tongue space so that I could have a less compensated neck posture, and then just improving my nasal breathing so that I didn't have as many sleep time episodes where I would end up in weird postures or having sleep disordered breathing kind of events that would cause me to clench, that would then lead to a headache cascade if I clenched that night severely.
And you did the whole physical therapy, Botox, all that stuff, I'm guessing.
I never did Botox, but I actually, yes, many medications, lots of physical therapy, lots of posture work, lots of massage, and other types of manual treatments to try to relieve the neck tension. They were always cervicogenic headaches in my case, so like
why
sort
not
of
Botox?
neck based. Why not Botox?
Yeah.
Because before I got to the Botox, I just ended up doing a migraine nerve decompression surgery where they just, instead of kind of neutralizing the muscles around the nerves, they just went in and just excised the nerves that were sort of culprit. Yeah, the occipital nerves.
Yeah, I'll be honest, that's not my area, so I don't know that much about it, but it is fascinating.
Yeah. When I was at Tufts, I was good friends with a doctor named Gilius Spearings, who was a very, very big headache guy. He was involved in a lot of the headache medication development that was happening at the time, the CGRP medicines. And he put on a conference at Tufts called, it was at the Tufts Craniofacial Pain Center, and it was a headache conference that I attended. And yeah, that's where I learned about people who truly just their entire career was just dedicated to headache, and about how varied they could be from patient to patient.
Yeah.
It's a huge black hole.
Yeah.
Yeah.
That's what happens when we don't fully understand something.
But for sure, just shotgunning expanders and jaw surgery at it is not the right way.
No, definitely not. And so, yeah, I tried to actually, so I work I have 2 chairs here, but there's actually 14 chairs total. And there's other providers here. So there's, we have dentists, my brother and my dad are dentists. We have all the dental specialties. And then we just added a plastic surgeon as well, and a headache specialist comes here too.
Wow.
So it's cool because we get to have all these different perspectives, and I can just like go down the hall and be like, hey, like, is this like a headache patient, right? Or like, do we need to do surgery on this patient? And everyone kind of like collaborate in real time, which is, I'm very, very lucky to have that. And I
reminds me of the Gelb Center,
which
is up the street from you guys.
Yeah.
Midtown versus downtown, right?
Yeah. Well, the Gelb Center is more like TMJ airway focused. But yeah, I know Michael well. He's a good guy. We actually run like the New York Airway Club together.
Oh, nice. Yeah, I've met him a few times. Awesome guy.
So, and you went to him as a patient, or just like?
No, when I was Dr. Nuaz's patient, Dr. Nuaz was the orthodontist at the Gelb Center. So I would go there for treatment.
Nice.
Before Dr. Montrose took over for Dr. Nuaz.
Nice, yeah. Small world, yeah. I know Jeremy well too.
Yeah.
So I was at the Gelb Center for like a few months. So I learned a lot.
Oh, you worked at the Gelb Center?
It's like like a work shadow type thing. Basically, like when I left my old job, I had like some free time, so I would go there like once a week. So
cool.
It was great. I learned a lot.
Yeah. Yeah. Did you get your hands into some MARPE stuff there as well?
I mean, yeah, we were like, going over like different cases, treatment planning. So I got to see more there as well. I mean, I didn't place any there, but we got to see it. So that was cool too, because I got to see, right, like a whole different type of patient that was getting the MARPE treatments.
The TMJ patients.
Yeah. That's why I talk a lot about too. Like patients, right? If they go see Dr. Gelb, right, they're more like TMJ patients, right? And so they're completely different than, let's say, patients that just go to my brother, my dad, that just want like a cleaning or some aesthetic work. And so you really have to hone in and talk about things differently. And and treat them differently. It's different when you have like an airway practice and people come to you and they're like, yeah, let's do MARPE. Let's do this. Let's do that. They're like ready to go.
And
Whereas,
that's not what the practice that you have now is like yet. It's probably becoming more like that as you become more popular on the
yeah,
channels.
it's becoming more like that, but I'm on Wall Street, right? So I have a lot of people in finance who how can I put this? Do they have sleep issues, airway issues? Some do, right? But these are like highly successful, motivated people. Maybe they've just kind of like gotten used to it, right? And they don't care. They just, they just want to fix a couple of things aesthetically. And so it's hard to have these conversations a lot of time and be like, hey, like you really need palate expansion, right? Um, I can show you some cases where bites are like super messed up and they have no issues. They're fine.
They're working 80 hours a week.
Yeah, or they're retired. They don't care. They just want a cleaning.
Yeah.
So it's interesting to see that spectrum.
I think that's really an interesting observation. How do you make sense of that? How do you make sense of the fact that some people might have a really minor malocclusion and it's like wrecking their life, or at least they think?
Yeah.
They're like totally preoccupied with it, ready to do double jaw surgery just to fix like a little bit of a posterior open bite or something because they're like holding their mandible forward or whatever because my airway. Versus like you have some Wall Street guy working 60 hours a week with a horrible bite, tiny airway, and is just plugging along and could care less. How is that even possible?
I think human variation, right? We're all different, and just some things affect other people more than others. I just saw Dr. Zaghi did a post about UARS and severe sleep apnea and how the UARS people actually suffer more than the severe sleep apnea people a lot of times, right? Isn't that crazy to think about that?
Yeah.
Yeah. Or you'll have someone, their blood pressure is like 180. You're like, you're about to die. Like, you got to go to the hospital. They're like, oh, I'm fine. So everyone just adapts at certain levels. You can think about it too, right? The people that live in the mountains and, that's what they're used to, right? And then you go up to high altitude and you're like about to throw up.
Yeah.
So there's just like so much different adaptability that that's all I can explain it with, right?
Do you think that there's a lot of psychosomatic phenomena occurring in the TMJ and UARS airway ortho space where people actually have like I don't know, they for whatever reason they become really preoccupied with this corner of their anatomy or with this kind of chronic condition that they have maybe it's objectively really severe, or maybe the fact that they're constantly thinking about it magnifies it to the point of it becoming what seems to them to be a disabling condition. Do you think a lot of it is just mind over matter and not in a good way?
100%. I don't know if you've talked about this before in your podcast, but psychosomatic is huge. I think, and it even happened to me, right? Like I was in dental school, I was in ortho. Now I start paying attention to my occlusion, all these different things. And I even I took sleep tests and like thought I had mild sleep apnea, right? So that is definitely a possibility. Now you see too, a lot of these orthodontists, putting in MARPE, FME. Would we have done that before, or would we kind of just dealt with it? That's a really good question to ask. I'm even considering it for myself, right? We're doing so many. I see a lot of the positive benefits, but like, would I have noticed these issues before, or am I just getting older? And as we get older, it's harder to adapt to certain things, right? Like you get a hangover when you're 21, you're fine, right? You get a hangover at 31,
Yeah.
that's gonna be a rough day. So I think it's a combination of both
Yeah.
things. But then right once you get to like 80 or 90, you're fine. Nothing affects you anymore.
Yeah. 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 Yeah.
You're like over that hump. So
Yeah. Totally. Totally. Yeah. I've been seeing on Instagram a lot of, well, I'm thinking of that guy Boython, who's
yeah,
considering doing a jaw surgery.
yeah. I actually met
And
him
he's
in
like,
person at the Alfie
where did you meet
conference.
him? Oh, you did.
Yeah,
Yeah. I think he's considering doing jaw surgery with Dr. Alfie
yeah.
specifically.
Makes sense.
And, you know, he says it's because his airway is cooked, his term, not
Yeah,
mine.
yeah,
And now, for sure, I've also considered doing jaw surgery too. And there was a long period of time. And to some degree, I still think that my life would be significantly improved if my airway were a little bit bigger. But I also know that to some degree, it's just because I think about it so much and because I think about this stuff so much that I even am thinking in those terms about, you know, it's almost like when you shop for anything, it sort of takes over your mind. It colonizes your mind. And then whenever you have a down moment, you're like thinking about that new camera that you want. And that's what you're Googling about. And it's like a virus that infects you, and then it just sort of takes over, even though objectively speaking, it's not that big of an issue for you potentially.
yeah.
Do you think
I mean,
that?
Boython, I met him
Uh,
in person.
yeah.
He's bigger than you think, like muscular, and he's tall too. Um, but I mean, when you look at him, I mean, like there's people that look like him and they're fine, right? But he is, we call it like a class 3. So I think his maxilla actually is like slightly further back and higher up. And so I don't think jaw surgery is like a crazy thing for him.
Mm,
Um, but I also know like people that look like that and you know they're fine. So
yeah.
that kind of adds to the variability as well. Um, look, jaw surgery is no joke. We're literally breaking your jaw apart, moving it forward. Um, and so there are risks that come with it. I think the risks have significantly decreased with custom jaw surgery and you know new techniques in medicine and whatnot. But there are still risks, uh, and and there is still like the healing period, right? I'd say it takes anywhere from 3 to 6 months for the swelling to fully go down, and that first week or two is rough. So
Yeah. 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 How do you think about jaw surgery, and how do you talk to patients about jaw surgery? Do they come to you
yeah,
at this point asking you about jaw surgery just because you're sort of an airway influencer? Or is it, and if so, what's that conversation
yeah,
sound like? And what do you look for in a surgeon to make you comfortable enough to refer someone out for such a life-changing, you know, for better or for worse operation? Like how do you get to the point of trust with a surgeon that you feel like you can put your name on that kind of referral?
yeah. That's a great point. So I'm blessed that I live in New York City and there's so many good surgeons here. Um, and so there's you know I work with some and I work with Dr. Alfie too in Texas. Um, and I would say it's the reason why I choose surgeons is based off two things. One is the ability for me to communicate with them. If they're not going to talk to me, then it's really hard for me to work with them because we really need to be on the same page, right? Uh, I have all these models right behind me and everything. Because what I'm doing is I'm testing, right? Like how can I get this bite to fit, right? This person here actually was talking about with Dr. Alfie yesterday, like, do we want to do it, just a Le Fort, like one piece, or do we want to do a 3 piece and whatnot? And so the fact that he just answered me the same day was super helpful. So that's one thing. The other thing is results, right? So when the surgery gets done, they come back to me, and if it's difficult for me to get their bite back together, that's just, that's not going to be fun. And then also the patient
Yeah.
experience. Like patients are very honest with the orthodontist. Usually we have like pretty good rapport with them. I've been seeing them every couple months. And so they're honest. They're like, oh yeah, great surgeon, not great surgeon. Their front desk sucks. So I take all those three things into consideration.
Yeah. Yeah. Who are some of the surgeons that you work with in New York?
Yeah. In no particular order. I work a lot with NICOMs. That's Dr. Newgarden, Abel, Gleed. They're private practice, but they also operate at Cornell. I also work with Artem Krutiansky. He's at Columbia. Dr. Sid Isaac. He's like the main attending there, and he's kind of like taking over for him. We met in dental school, and he's a great guy, like very aesthetic driven. There's also my other friend Justin Sita. He's private practice. There is Todd Hanna. He's private practice. There's Dr. Bookbinder. He's at Sinai.
Wow.
Who else is there? And then I haven't done a case with her, but, Courtney Cho. She's like an ENT. I have a couple of friends that have worked with her, and they said she's good too. She was like,
For double jaw?
yeah,
Oh,
I know.
did she do like that sleep surgery training with I forget his
Yeah,
name, in Pennsylvania?
no, in at Stanford.
Oh, at Stanford. Okay.
Yeah. I haven't done a case with her, so I can't vouch for her. But my friend said it went well, and she's like very smart and like knowledgeable, and she gets it.
Mm,
So I think I named everyone in New York that I work with, and then there's another group in Jersey, Aziz and Jacob.
yeah.
And then they're in Long Island, Ellie Rosenfeld. She's great too.
Wow.
Sorry if I forgot anyone.
Hey, you did pretty good, man. I think you just
Uh,
put a lot of new names on people's radar.
okay, cool. And then there's obviously Dr. Alfie and his associate Halepas, and they're in Miami and Texas.
Mm.
So
Yeah,
that's
people put so much emphasis on choosing a surgeon. Do
yeah,
you find that a lot of that energy is spent really just negotiating like a roughly 10 to 15% difference in actual outcome if you're working with a certain class of surgeon? Or do you feel like the results can truly vary wildly if a person doesn't very, very carefully choose the right surgeon
yeah.
for themselves?
Good question. So the surgeon definitely matters. Um, I think, and I don't want to get into it because I'm not a surgeon, but custom jaw surgery, like the VSP planning, I think is important. I'm not going to get into like whether the lower jaw, because I know a lot of surgeons don't do the lower jaw custom; they only do the upper jaw
It's
custom.
true, yeah. Do you
Um,
understand that from a technical point of view, why that's done? Why
I
some people
do.
think it's crazy to use custom on the lower jaw or to do the upper jaw first?
I get it. And first of all, I'm not a surgeon, right? So I'm not like the one to be talking, but from talking to my surgeon colleague friends, from what I understand, if you do fully custom, then you don't have to worry about setting the mandible in the exact right place, because then all that movement, um, like in all three planes, is set, right? Now, if you only do custom for the upper and you basically set the lower to the upper, it should interlock pretty well, but there's still like some wiggle room where you could basically not get in the exact same place. The condyle, there's a chance that the condyle might not be seated, like all these different things. Um, does that make sense?
Yeah. Yeah, my understanding, and
Yeah.
by the way, I'm visiting a surgeon named Steve Sullivan
He's in the
next
Midwest or
week.
Florida?
Oklahoma.
Oklahoma, yep. Okay.
Yeah. And he's very big on this issue.
Yeah.
And the way he explained it to me was that if you try to do custom on the lower jaw, you're essentially trying to predict how to properly seat the condyle in the VSP. And that's almost impossible to do. It's more of a tactile thing. It's more of like you want to see how the mandible kind of auto rotates and still feels comfortable in the condyle. I'm sorry, in the fossa.
Yeah.
In the OR. Whereas if you're doing custom for the lower jaw, you're essentially forcing a certain condylar position that may or may not be actually a happy place for the condyle. And so,
And
yeah,
what
I
I
think,
understand too is like it's the custom. It's more of a learning curve. Like when you do custom for the lower, that's what the surgeons have said. So it's more of a learning curve, and it's more money. And
yeah,
so that's
yeah,
why I think a lot of surgeons don't do it. But I think what I've heard, once you do learn it, it actually makes it easier and more predictable. Um, but I see what Sullivan's saying, and that's what I'm saying. I'm not a surgeon, so I don't know how it feels to put the condyle, in the fossa.
yeah,
Um,
yeah.
but from when I went to Alfie's symposium in Miami, what he was saying was even if you get it seated right in the right AP, right anterior posterior dimension, you don't know exactly where it goes in the yaw. So it could still be like a little fur out or in, like because it's rotating in that way. And so that's where the custom comes. Like that's why the custom helps.
Because the custom forces the proper yaw orientation
Yeah.
of the two segments.
So what he's saying, right, is like what Sullivan's saying is once you need to be able to find it, right, to see exactly where it is. But finding that position is only an anterior posterior and 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 uh and up and down, right? But it doesn't actually tell you like the rotation wise. So sometimes people when they don't do custom on the lower, it could be like the jaw could be too rotated out or too rotated in.
Mm, mm,
Um,
yeah.
so you'll have to get like two surgeons on here to debate it out.
No, I know.
I think that'd be really cool. I don't know if you ever had two people on it,
I would
but
love to. I would love to. Yeah, I mean, I would love to have, say, Dr. Sullivan and Dr. Alfie debate.
yeah, that'd be cool.
I think that would be really cool.
And the one who I mentioned, Ellie Rosenfeld, she like does both. And she was telling me like why she likes to do some over the other. So maybe you could have her even talk about it.
Mm.
So it's an interesting topic. As I said, I'm not a surgeon, so I can't like tell you for sure.
Of that cast of surgeons that you mentioned, how many of them are doing what you would call custom jaw surgery?
It depends, because like every case is different, right? But back to my point though, what I was saying was I actually had a patient go to another surgeon in New York, who I'm not gonna mention, but this person wanted to do SARPE and lower jaw surgery at the same time. To like, because I guess insurance would pay for it, and like, could you do it that way?
Like a sagittal split on the lower jaw to advance it, or
No.
or like
They
a
wanted to move
mandibular widening?
They wanted to move the lower jaw forward and do a SARPE on the upper at the same time.
Okay.
But it just seemed that it didn't like make sense to me. I was like, why would you not just do the MARPE first, expand everything, get improved nasal breathing, have it be more stable, and then you could do double jaw surgery to move everything forward.
Yeah. Yeah, of course.
As I said, could you do it that way that he said, to do the SARPE and the lower jaw at the same time? Yeah, but it just like, it's not as predictable. You're not getting as much airway improvement, and it's a lot for the patient to recover from.
Yeah.
Right.
Yeah.
So.
Yeah. Yeah. What? Yeah. No, I totally understand, and these are. Yeah. People, the number one question I get is how to choose a jaw surgeon and who to go to for jaw surgery. And the more I learn about it, the more I just don't have good answers to that question, because it seems like every quarter some new surgeon is trending, some new surgery is trending.
Yeah.
Like right now, Dr. Bobeck is very popular. Do you know Dr. Bobeck, for example?
No, where is he?
He's in Seattle.
Okay.
And he does a lot of kind of funky stuff. He does, inverted L's and Z's, and he does, midline mandible osteotomies to get mandibular widening. Is that something you've looked into at all to combine with your MARPE treatments? Is mandibular skeletal
Yeah,
expansion?
I've just never found the need for it.
Hmm.
I think most of the patients that have, the lower jaw looks narrow. I don't think it's actually narrow. I think it's just too far back, and they usually just need a mandibular advancement.
Hmm.
Someone showed me, I had one person, like they sent me a case and they did the MSDO on it. And I was just thinking to myself, I don't think they really need it.
Yeah.
It just seems like a very invasive procedure, right? Talk about black triangle. Talk about it's just like the bone there. It's so much cortical bone. It just doesn't make sense to me.
Mm-hmm.
I'm open to learning about it, and I'd love to see some more before and after cases. But in my experience, I've never seen a patient that would have truly benefited from it.
Do you generally tend to do more modest expansions? Like, are you like more of a 4 to 7 guy rather than like an 8 to 12 guy? I find that people live on different sides of the spectrum on that. Because I feel like if you keep the volume down on the expansion, then no, you definitely don't need mandibular skeletal expansion in most cases. But I just know that a lot of providers are really pushing expansion like really far for whatever reason.
My question for those providers is, if you're going past the norms, are you getting any benefit? Or does that person really just need double jaw surgery to move their jaws forward?
Yeah. Well, I think
Right?
that's part of the intention, is at least on the upper jaw, to kind of get a Lefort-like change just through a really huge amount of expansion to get that advancement that comes
Yeah,
from big expansions.
that's fair. But like, let's say, first off, I don't like to talk in like absolutes, like, oh, I'm a 4 to 7 guy. Because like, if a patient needs 4 to 7, then we'll do 4 to 7. If they need 8 to 12, then we'll do 8 to 12. So I wouldn't like categorize myself as one of those. Um, but I do think if you're expanding that much and the patient doesn't need it, right? So let's say you expand 12 millimeters and now you have to do a MSDO on the lower. Did that person really need that? Or did they really need double jaw surgery to move their jaws forward?
Mm.
Now, is there research that double jaw surgery is one of the best ways to cure sleep apnea and sleep issues? Yeah. Is there anyone showing that if you expand a crazy amount and you do a MSDO, you're curing sleep apnea? I don't think so.
Mm. Mm.
And yeah, at that point, once you're doing MSDO, just do double jaw surgery.
Yeah. Yeah.
Right?
Although they do different things, right? Like one is transverse and one is AP.
Yeah.
And so,
True.
like,
Yeah.
for example, Dr. Movahead talks about actually doing both,
Yeah.
what does he call it? MME, MMA, right?
Okay.
Where, especially for like patients that have, that can't afford to come far forward, but still have sleep disordered breathing. They can't afford to come far forward for cosmetic reasons. I think he specifically referenced like, East Asian patients, for example, on that, where it's kind of hard to do big advancements because the midface just generally can be flat.
Okay.
That
Fair. If you're doing
yeah.
both together, fair. Fine. Also, too, is it possible there are people that truly only need transverse expansion? Sure. I'm just saying from all my patients that I've seen, I haven't seen that. I would say most people that need MARPE also would benefit from double jaw surgery.
Yeah. Yeah. No,
Right?
and I would actually agree with you.
If you think about it too, right? Like why, if we have like mouth breathing, airway issues, whatever, why would only the palate be affected in the transverse dimension?
No,
right?
Totally agreed.
It's the whole complex that didn't properly come forward. So that's why you would need both.
Yeah, right.
But
right.
look, as we said, right, individualized care. A lot of people can just get a MARPE and then they're happy and they can go on living their lives. Doesn't change the fact that their jaws are still recessed in the anterior posterior dimension, but
Yeah.
at least they're happier.
Yeah. Yeah. And by the way, I've often said that you should never try to expand your way out of the need for a jaw surgery, or that MARPE, I've even said that MARPE tends to go wrong when you try to use it to replace jaw surgery, because that's when you get greedy with MARPE, and that's when you can start introducing big complications around overexpansion,
Yeah.
and especially overexpansion combined with an asymmetry. That's where you get the catastrophic, cants and sort of asymmetries in the midface, etc. So I would agree with you.
I appreciate you keeping it real with people.
Yeah, well, reality comes back to me, just like you said. Whatever you throw out comes back to you, and so like, I have a platform, and so I have a responsibility to be as committed to the truth as possible. And if I'm seeing things in the field, and by in the field I mean in the patient advocacy field, patients going out and doing things and then coming back to me and telling me how it went, like, I just report on what I see.
Yeah.
So, and that's what I've seen over the years.
Yeah, people also to add to the asymmetry thing, I think people don't listen and they just keep on expanding. And when you expand too much or when you expand too fast, that's when things go wrong.
Totally. Totally.
It's crazy to think too, right? Like like before COVID, people were expanding super fast, large diastema, and now we think back to that and we're like, that's crazy, right?
Yeah.
We were going so fast that we were actually breaking other sutures in our skull from the force.
I mean,
Like,
I'm still seeing people break other sutures even when they go slow if they expand too much.
oh yeah. What about, have you seen anyone break sutures if they don't expand too much and they go slowly?
No. I've seen a person break a suture with FME.
Going too fast?
Too much, just a lot. Like, too much is like a value statement, but a lot, I'll put it that way, expanding
Like
a lot.
too many
Like,
turns.
yeah, it was roughly an 8 millimeter FME expansion, and I believe there was some kind of suture disruption up here, frontomaxillary suture potentially, and then there was a one-sided drop.
Yeah. I mean, think about it, right? Like you're going like this. Like that suture is affected there.
Yeah.
So yeah, I'm not surprised. But the back turning is, I've seen and I've heard incredible, results from that. It seems to fix a lot.
But can you back turn that specific complication? Do you think you can back turn things up?
Well, like let's say
up into here?
Like let's say you fracture or you get asymmetry or something, then yeah, you back turn, and then things will go back to kind of where they should hopefully go back to where they were.
Yeah.
And heal a little bit.
Yeah.
But yeah, exactly what you said. Like if you're going too much, that's why all these people, they're like, oh, like FME doesn't cause asymmetry, or this doesn't cause fracture. None of that matters. It's really the protocols, right? The placement of the TADs, individualized anatomy.
Yeah.
That really affects that.
Yeah. I mean, I think the tool matters too, and I know you're not saying it doesn't, but I think that it's not only ever just about the tool.
Yeah.
Like, I think FME does have some intriguing benefits around asymmetry issues, specifically in its dimensional stability, in the vertical, as Dr. Manueli explained when he came on. It just doesn't do this, right? It
Correct.
doesn't do this. And so, and that's nice if there's differential forces collapsing back down on the appliance on one side more than the other, it might hold. But I mean, you get to a point where if there's so much disruption from such a big expansion up here, it's like the whole thing will just go like this.
Yeah. No, I agree 100%. And then to go back to the FME, the reason why I was intrigued was the dimensional stability. Like I saw that video where he literally compared the two, and that was like a great visual representation. And then also the other thing too is basically when you put it on, you don't have to add the like composite or like the different ties. to prevent the screws from like, or the appliance intruding, right? So that helps the
Because of the
orthodontist a
locking
lot.
tads.
Exactly.
Mm.
Uh, Otherwise you have to add like, like Lipkin has these ties. So you
Yeah, the
actually
Lipkin
like,
ties.
yeah,
The Lipkin wings.
yeah, the Lipkin wings. So you
Yeah.
have to add these ties to the MARPE so that the tads don't slip.
Mm.
So I mean, it doesn't take crazy amount of time, maybe 5 minutes to do them, but it's still something
Mm.
that
Mm.
you have to worry about. And you also, I don't know if you, whenever you see a MARPE, right, there's all this composite, all this wax everywhere. You don't see that with FME, right?
You mean from like a patient comfort
Yeah,
perspective,
patient
just because there's
comfort.
so many potentially abrasive points on it?
Correct, exactly. So that's nice too. Um, and yeah, the dimensional stability. Um, and I'm interested in the quality of the expansion. I don't want to say that the quality of the FME is better, but it is interesting to see, you know, all these people reporting like more parallel expansion and whatnot. So we'll see.
Do you follow Shui Kai's work at all in the UARS news subreddit? Do you know
I
who Shui Kai is?
I don't follow him, but I have like a text group with him.
Oh, nice.
So he'll like send me the articles and I'll read it there.
Oh,
Uh,
cool.
it's really interesting that he's not a medical professional and he just knows a lot. He's like you.
Well, he's like your friend
Um,
Kevin. Kevin, is that his
no,
name?
Matt, Mark.
Mark. He's like your friend Mark.
Yeah, I got to get all you guys together in like a group chat. You guys could solve all the everything.
I don't solve
Uh,
anything, man. I just bring other people on and give them the chance to say what's really happening in their practices.
no,
I very much know, the scope of where I belong and where I don't. So,
yeah. What do you what are your thoughts? Do you hate retraction? I mean, it's not retraction, extractions.
like one word answer to that question, yeah.
Yeah,
But like
yeah,
also in the context of jaw surgery, I don't know. I guess I'm open
yeah.
to it if it gives you a bigger bony movement.
Okay,
But
good, perfect. Because
yeah,
I get a lot of patients that I'm like, can we please extract your teeth so that I can get a better movement? And they're like, no, I don't want to extract teeth. And I'm like, dude, you're killing me. Like I'm moving everything forward. They're like, yeah, but once you get less tongue space, I'm like, temporarily, and then I'm gonna move your jaws forward.
yeah. I describe it as
So
sacrificing the pawn to get the queen.
that's great. I'm gonna use that. Thank you.
Yeah. Oh, sure. Yeah, sure. Um, yeah, I mean, there's also in any holistic health space, you get all sorts of ideas, of course, but there's people that believe that when you take out a tooth, it messes with, energy systems and meridians and like sort of like pranayama, Chinese health, Buddhist meditation type
Yeah,
energy flows in the body. And I mean, as a former hardcore meditator, I get that. But yeah, I think that going down those sorts of esoteric idea pathways can make you very untethered very quickly, and then you end
yeah,
up losing sort of the more tangible, real benefits of getting an additional 6 millimeters of advancement in your jaw surgery, which it's very discreet how that would help you. And so again, I would say only when necessary. Like I wouldn't proactively be going out and looking to do extractions
yeah.
for a jaw
No,
surgery, but I know Dr. Movahead does it all the time.
yeah,
And for some people, it's the only way they can get a certain size bony movement without looking uncanny.
yeah. No, I actually I actually had a patient referred to me by the jaw surgeon to extract lower premolars and decompensate, but I actually thought we could do it without it. So I did it without, and it's going pretty well. But as I said, everything's individualized, right? Everything
Yeah.
depends. The main thing I would tell people like that we got to look at is the lower incisal or like the incisor inclination, right? Because the more something is inclined, right? Like let's say it's like this, right? Then I can't move it anymore. But once I move it like that, then I can just move it so much more. And
Mm.
so you get the whole jaw to move forward. And then it's also better too for the periodontium and everything over time. Uh, but
Yeah.
hopefully this stuff, hopefully in like 20, 30 years, or I guess 50 years, everyone just is properly treated as a kid, and then we don't have to have any MARPE or jaw surgery. Wouldn't that be cool?
Yeah, I know you have a daughter, right?
You have a daughter, yeah, a year and a
Are
half.
you doing anything differently for her in terms of her upbringing, given what you've seen in the field with
Yeah.
underdeveloped patients, or do you think that there's nothing to be done? Does the environment matter? Are there ways you can intervene to guide growth, or is it all just genetic? Where are you at with that?
So theoretically, right, they say don't use a pacifier. It is so hard to deal with a crying baby that sometimes you got to do it. So yeah, does she have a pacifier in her mouth all day? No, but it helps her go to sleep. So she probably has a pacifier like 20 minutes a day
Hmm.
that we're at. Do I wish she didn't do that? No, but parenting tough, man. It's tough. And also too, people say she should be chewing chewy foods, right? Meat, all this stuff. Dude, I can't get her to eat more than pasta and veggies and fruit. It's really
Yeah,
tough. Like, so all these
I
things, like
know.
people say, do this, or they said, oh, like your baby should be born naturally. They should breastfeed. What if my wife had a really tough pregnancy, not pregnancy, really tough birth, 40 hours. She tried, it didn't work
Wow,
out, ended up being a C-section, right?
wow, wow,
So, and
wow.
then
I
after that
get it.
experience, it's really hard to breastfeed. And so I appreciate like everyone saying, yeah, you got to breastfeed, do all these things, but like you got life, right? And
Yeah,
it's really hard to do certain things that people recommend. Um,
yeah,
so I'm trying my best.
yep, yep.
Um, but also being a parent is tough, and you really want your kid to be healthy and happy. And so a lot of these recommendations are tough to implement, honestly.
Mm.
Um, so
Yeah, I couldn't agree more. Yeah, everyone has a plan until they get punched in the face, right?
yeah.
It's really easy to raise a perfect, like, huge jaw child on paper.
Yeah,
It's really hard to do it in real life. And
yeah,
even then, with theoretically perfect stuff, diet, habits, you still see patterns of underdevelopment. And so there is for sure a genetic
yeah,
component. It's a messy process.
yeah.
It's a messy
But
process.
but I'm definitely gonna be watching her, right? Like we do little things, for example, like when she was sick and she was congested, she couldn't breathe through her nose. So we use you like actually like suck out all the snot. And we're really good about doing that because I mean you don't want her to mouth breathe, but also, she's congested and all this stuff. And so I think there's like little things like that that I think we're doing really well. And I feel like it's helped a lot. We also have like an air filtration in her room, so it's not too humid. All these little things that I do think are helping a lot. For peanuts, we like slowly introduce them so she wouldn't be allergic to them. Um, what else is there? I think that's pretty much it.
Yeah. Yeah. The nose Frida. Is that what you're talking
Yeah,
about?
yeah. I mean, it's tough. It's tough to do that, but I think it's really important.
Yeah.
Um, I'm
Have you ever plunged the nose? Have you ever neti like done the syringe neti little mini neti pot to go up
no,
one and down the other?
no, we didn't do that. We just sucked it through. But maybe
Yeah.
maybe next time she's sick. By the way, they
Yeah.
get sick every month.
Try it out. I know. I know. I know. I get it. I get it.
Um, so yeah, yeah, you just don't want them to die. That's the main thing.
That's certainly a hell of a place to start. And honestly, it a lot of times it feels like that's the only thing that's achievable when things get messy enough.
Yeah, yeah.
When
Um,
would you be looking to potentially do orthodontic intervention on a child in general, if needed? Are you like
yeah.
a age 5 is
So
ideal, or later or earlier?
good question. So I this is a hot topic in orthodontics. Have you talked about it on the podcast yet?
I have with
Uh,
different people over the years. Mm.
yeah. So I would say for first off, have you ever tried to get a little kid, a 3, 4, 5-year-old in a chair?
I can
Not
imagine.
not easy. Even I had this one girl, she's 5 now. She tricked me. She seems so sweet, and now uh, she has her moments, but it's tough. Even and I would say she's probably like the best behaved 5-year-old girl. Um, I would say a lot of the issues that we're seeing at 3, especially 3 and 4, they really need to be seeing like a properly trained ENT, right?
Mm.
Figuring out what's going on. Are there allergies, right? Is it a tonsil issue? Something like that. Maybe, or maybe a myofunctional specialist, right? Is there a tongue tie? Something like that. Um, I've never treated a 3-year-old um, yet. Not to say you don't, it's not possible. I mean, there are, when you're talking about cleft craniofacial, right? Those kids are treated right after birth, you know. So that's one thing. Um, I'm usually, if I'm treating kids younger than 7, it's because it's like a severe issue, right? And there's also that sleep airway component.
Mm.
But I'll be honest, I'm really not doing much.
Mm. Mm.
Mostly, I'd say most of the kids I get that have that, they really just need to see like an ENT. They usually have like enlarged tonsils, something like that. And their teeth usually look their teeth actually look, there's proper spacing and everything, right?
Mm. Mm.
Um, I mean, I can show you. Let me see if I have anyone.
Yeah, sure.
Uh,
Be happy to see it.
yeah, let's see if we have. Let me pull up. All right, sorry. Oh, I'm sorry.
Do you know of anyone doing skeletal expanders in young children?
Yeah, so this one guy actually reached out to me on TikTok, and he told me he was doing an MSE, no bands on like 7, 8, 9, 10-year-olds. And at first I was like, that's crazy, right? Like it just
Is that
sounds
Dr. Ting or is that someone else?
no, I forget his name honestly. It wasn't Ting. I know Ting.
Okay.
Um, because
Mm.
if you like, we know we can actually get expansion 7, 8, 9-year-olds with a regular expander, right? Um, what the guy was saying was you get dental movement when you do the expander, which also we all know that. I'd say you get about like 50-50, right? So 50 skeletal, 50 dental. Um, but the way I do it is I just overexpand with a regular RPE. And so I know I'm gonna get the relapse, and that's fine. It just feels like, as I said, like
Mm.
ideally, would it be better to do an MSE, like a no band expander on a kid? Yeah, 100%. Like, but I can't imagine how hard it is to anesthetize them, to put in the screw, to do all these things. Uh,
Yeah.
so
So
I've
that's
not done
the
it.
issue then. The issue is putting it into practice. It's not that the tooth-borne expander is better from a theoretical point of view, like when it comes to quality of expansion. It's just a matter of getting the expander into the kid's mouth without the kid suffering too much and having a meltdown.
Correct.
Right. And so you would probably need anesthesia to place a TAD expander in a child, right?
Yeah, I mean, do you have to? I wouldn't knock them out, but yeah, you'd have to do local anesthesia.
Yeah.
Um,
Well, but I mean, let's say you wanted to do a TAD expander in a 5-year-old or a 4-year-old.
no, I would
Like,
never do that. No, no, never.
why not?
There's just too much going on.
Like
There's
what?
zero chance. You can't. It's hard enough to get a regular expander in. Um,
Just to actually place it or what?
so the reason why I wouldn't care at that age is because you can just put it on the primary teeth, and so who cares if the primary teeth move out of bone?
But what if they're so young that they don't have primary teeth that are
Oh,
strong enough to expand to anchor the expander, like
oh,
a
then
4-year-old?
then you got to do an MSC,
Do you know
or
anyone who's ever done that in a 4-year-old, say?
only on kids with like craniofacial issues.
Right.
Yeah.
So, okay, so that's not uncommon for kids that have syndromic conditions. They're
Oh yeah,
born
of
with.
course. Yeah, but they go to the OR like you know, an oral maxillofacial surgeon's doing
Mm,
it.
mm.
It's mostly kids with wow, I'm missing. They have like the midlines fused. I really should know the term for this.
That's okay.
Um, but yeah, so they have to do it for that. There's no teeth, right? They
Mm,
usually do it at like 2, 3 months,
mm.
because the suture is fused, so they do a cut, you know, open the suture, and then they put the expander in,
Yeah.
which is pretty cool. Here, like I'll show you this here. Let me pull it up. I'll share my screen. Window. Okay. So I'd say this right here is like a borderline case, right, for a kid, right? So does this kid have a narrow palate? Yeah, right. You can already start to see the crowding and everything.
That looks exactly like my daughter's palette.
Oh, you have a daughter too? Nice.
Yeah, a couple of them. Yeah.
And you can start to see the crowding here on the bottom, right? There really should be spacing. But guess what? This kid won't sit still at
Mm,
all.
mm.
So what are you gonna do? Uh, my recommendation here was just, you know, myofunctional therapy, see the ENT, do all that stuff, and eventually we'll do an expander. But you know, you don't want to like necessarily traumatize the kid. Um, and so if someone wanted to do expander here, I wouldn't be opposed to it. But also, I think the ideal would be actually addressing all the other issues, tongue posture, allergies, tonsils, everything, and then allowing it to grow,
Mm.
the patient to grow. And then he'll show you,
Or you'd have to knock that child out to place the expander.
yeah, and I'm not doing that. Um,
Are there people that do that? Are there really progressive provider? I don't even know if progressive is the right word. Are there really avant-garde providers that are anesthetizing kids to put expanders in at that young of an age to get them
like
that skeletal expansion?
knocking them out, not that I know of any.
Hmm.
Uh, so you know, I'll show you this. I'll show you this other one too. This one here. So for me, right? You see this here.
Mm.
You see, look, are they class 2? Right? We're looking at the molar. Yeah. So does that mean the lower jaw's a little bit back? Yes. But for me, like, look how much better this looks, right? You have some spacing here, right? You have spacing there. I would not do an expander here. Now I
Mm.
know I'm sure there are some people that would, but I wouldn't. What do you think?
I think that palette looks pretty respectable to me. I mean, I can
Yeah.
imagine that person 10 years from now with a pretty decent arch.
Yeah,
This doesn't scream out to me as any kind of problem at all.
I agree. I mean, if you look up here, right, it's a little bit narrow, but as I said, I think if you just do myofunctional therapy, make sure all this other stuff is working properly, then I'm okay.
Now, why in this, like, is it common for kids where you see the lower teeth tipped in aggressively like that? Like, if you see that in an adult, it usually screams, oh, narrow palate. But in that
Yeah.
child, it also looked like the upper teeth were tipped in pretty aggressively. Whereas in
Which one?
adults,
The first one?
the second one, it looks like
Yeah.
all of the teeth are tipped lingually. Is that
Yeah, so
just
there's like
common with children?
there's a natural amount of inclination, and I'll pull it up again, sorry. There's a natural amount of inclination. Also, the primary teeth, like they actually are more just like the shape of it. They have more of that incline.
Hmm.
And so it looks, let me share it again. Okay. I mean, this looks pretty normal to me, honestly.
Mm-hmm.
You're starting to see like a little bit of the curve of Spee develop. So there are like signs of like, okay, this is kind of going awry. But as I said, if we kind of work on all these other things first, um, I think the body can kind of like reorient itself and the teeth can kind of reorient itself.
Yeah.
Uh,
What is like the elevator pitch about how curve of Spee is to be understood? Like when you see that curve there, maybe you could
Yeah.
just trace it with your pointer and just
Yeah.
explain what curve of Spee is. And what does it mean when you start to see that? Is that
Yeah, of
an
course.
indicator of something unhealthy?
Can you see it here? Yeah, here you go.
Yeah, I can see your pointer.
So
Yeah.
normally this should all be kind of like flat, right? And so the curve of Spee is basically, it refers to this lower portion being like higher up. Okay. And then here you can kind of see, right, like this is kind of like a reverse smile line. So you can see these upper teeth are kind of higher up.
So curve of Spee is always mandibular?
Yeah, we're talking about the mandibular.
Yeah.
We also look at it from this angle here as well too. So as you can see, the lower teeth are kind of lower down, and then it comes up here at the incisors. So there's like a natural curve of Spee. And then you also have the curve of Wilson, and that refers to the posterior teeth, like when they're angled in. There's like a slight curvature like that. If like your teeth are completely flat, then there's no curve of Wilson, and that's not exactly natural. Okay.
So does curve of Wilson get blown up a lot in MARPE treatment because you're uprighting the lower teeth so aggressively often? No, not you, but generally.
I would say it doesn't happen too much, and that's just because you have like the cortical bone, and so it's hard to kind of push the teeth like fully that way because the cortical bone, right? If we think about it, the cortical bone is not, it's not like that. It's not like, they're not like parallel. The cortical bones are like that, and so the teeth naturally can kind of only go like that. Does that make sense?
Yeah, unless you disrupt the cortical bone with like SFOT or something, and you blow right through it.
Exactly.
But then does an absence of curve of Wilson indicate sort of long-term periodontal risk because now the teeth are not oriented in the bone the way they should be? Or is that not a fair statement?
I don't think it's a fair statement. The only periodontal risk you have is like if you push the teeth out of the bone. And even that, right? We don't know. It's possible. Let's say your teeth are out of bone. It's possible that you don't get any recession because you actually have like really good gingival biotype, and so you have like thick tissue and the teeth kind of stay there. But then you have no bone, right?
Yeah. When you were in orthodontic training in 2018 to 2020, and it sounds like you were online at that point, sort of in the darker corners of airway orthodontics. Darker meaning like cutting edge, let's say.
Okay.
Like,
thanks.
Okay, like learning about expanders and whatnot. Were you seeing some of the tooth-borne stuff that was trending at the time, and it was a raising alarm for you? Like, oh, you can't do that. You can't just push teeth forward or through the bone like that. That's not going to turn out well. Or, or what was your reaction at the time to things like AGGA and to this day, what do you think of things like ALF and other tooth-borne expanders that are done in adults?
So first off, oh my God, there's so much to say. First off, for ALF, I looked it up. It's not actually an expander. And let me tell you how they describe it exactly. They say ALF, let's see, oral orthodontics.
A growth appliance or an epigenetic appliance?
They say it's to guide jaw development in straightened teeth. It's not an expander. People use it as an expander. They say it's an expander. I'll be honest, it doesn't make sense to me. And I've had to like my old practice, like they did a couple ALFs, and so I like had to adjust them, and it's just like a light wire. I don't know. It doesn't make sense to me.
Yeah, sure. It's definitely not splitting the suture, right?
No.
No, you need 10 dads to split the suture in a lot of cases. You're not doing it with a light wire, right?
No. And if you're using ALF on an adult, like I don't know. That's more of like a psychological thing.
Like a placebo?
Maybe. I don't know who's doing ALF on adults.
I know people that are doing it. Oh, yeah.
Why?
Well, I think because there's a lot of delusion.
Yeah.
I mean, that's what I'm asking you about. Like, how were you reacting to what I would describe as a kind of mass psychosis among
Yeah. So first
so-called,
off, like a DNA appliance, do you know how much it costs to become a Vivos provider?
can I guess
Yeah, guess.
10,000?
$50,000.
What?
Yep. And then I just heard there are providers that teach you how to become advanced providers, and I heard that costs like hundreds of over 100,000.
Oh,
So
interesting.
it just feels like a pyramid scheme to me. If you like, and also the device too, they sell it, like the dentists have to buy it from the lab for like $2,000 or something. That appliance should really cost maybe like 1,000 or less. So it's just like a, you know, an acrylic appliance with some some springs.
Yeah.
Um, is the appliance could the appliance help move teeth while also like it provides an occlusal blight block, so it can help disarticulate, which some patients like for TMJ, right? It can actually help some patients. And it can also move the lower jaw forward, which some patients like for sleep. So it's actually kind of cool that it can do three things, right? It can move teeth, it can help with the TMJ, and it can also help with your sleep.
Yeah,
But
by to be clear, by repositioning the lower jaw, not by growing the lower jaw. Yeah.
Repositioning, yeah.
Yeah.
So it's cool that it can do all those three things, but practically it is hard to move teeth with just a spring, right? It doesn't have 3D control. It's just like a pushing. So there's limits there.
Like if you want to move teeth, there's better ways to do it.
Correct. Yeah.
Yeah.
But yeah, let's say for, you know, hypothetically, let's say someone can't tolerate Invisalign because it's not for everyone. It's a little bit more chewy. So when they're actually like chewing on the Invisalign, it actually causes more stress in their jaws. And so great, you can use this appliance, cool. And then you can also, let's say you have sleep apnea and the lower mandibular advancement appliance helps you, great. But to say that it is changing your DNA or that it is curing your sleep apnea, like all these things, like give me a break, give me a break. Or to say you're getting actual jaw expansion, like you're getting change at the suture by, I don't even know how to say it. Like, no, it's not happening. It's not happening.
Yeah.
And it's funny, I actually like was debating this TikToker guy, and he was
Which
like
guy?
super Truth DDS.
Oh yeah.
Yeah, and he was like super pro Vivos.
Is he still pro Vivos?
No, now he sees the light.
Okay.
He likes MASPE, MARPE more. Does he still think Vivos can help some patients? Yeah, it can help some patients, but I think he realizes you're not getting actual expansion.
But it can help those patients in the way that you described, not by providing actual skeletal augmentation.
Correct. It's more so, I think, look, I think some people probably feel a little bit better once it moves the teeth a little bit. So they get a little bit of expansion by moving the teeth. Like dental expansion. You're not getting actual expansion. So I think just a little bit is enough to help some people. And great. I'm so happy for those people. But don't lie to them and say you're getting actual expansion, right?
Do you know any orthodontists that use Vivos?
No way. Why? Why would we waste our money and pay $50,000 when we just went to residency?
It's general dentists that tend to use Vivos.
Yeah, it's geared towards general dentists that didn't have like an orthodontic training, and so maybe they don't understand growth and development as much, and they think that the appliance can do more than it can do.
So this was one of the things that I tackled in my book, the JawHacks Field Guide. I was trying in chapter 4 to understand how we got to the point where so many dentists were using these types of appliances and were convinced that there was actual skeletal growth happening. Yeah. And I just came to the conclusion that they just must not learn in dental school that when you push teeth transversely out in the arch, like you push teeth this way, that bone doesn't grow, bone resorbs. Right? Is that because like you aggressively push teeth?
Depending on the inclination of teeth, you can push them out pretty far. And you're not like pushing them out of the bone. You have remodeling and whatnot happening. And so a lot of people see that and like, oh my God, like look how much it expanded. The teeth just moved in the arch. You got arch development. Arch development, orthodontists have been doing forever. It's a
Yeah.
very popular concept.
Yeah. But
Uh,
in the first 4 years of dental school, are you not taught that there's limits as to how far that can go?
no, zero chance.
You don't learn that in dental school.
No.
But I thought there's a little ortho component in dental school.
Yeah, you learn how to make retainers, and you learn about like tooth movement biology, but these are like these are like com these are topics you don't learn at all, I would say, in dental school.
So then it's easy to fall victim to the seductive idea that like there could
Yeah.
potentially be these growth centers that when you stimulate them using expensive appliances,
Yeah.
growth gets turned back on, almost like turning the faucet back on
Yeah. I mean,
after the winter ends.
even James Nestor wrote about it in his book.
Yeah, I know. I've criticized him about that.
I love that book, by the way. I give copies to patients.
Do you tell them to skip the last few chapters?
I really should, but I don't.
It's like the Communist Manifesto. It's great until the last chapter.
But yeah, these people, so think about it. James Nestor, super smart guy, right? Dentists, they're super smart. They went to school, but the people promoting it are just like really good marketers. And when they talk, you're like, oh wait, that makes sense. But then you think about it and you're like, no, it's impossible. And I've never seen a CBCT to show actual skeletal expansion. No, never.
Yeah. And so then it's like, is this deliberate, untruthful marketing where you're trying to sell even though you know that what you're selling is not doing what you purport that it does? Or is everyone just drunk on the Kool-Aid?
Great question.
Or is it a few people at the top that are know that it's not true, but all the underlings, because they want it to be true, they therefore believe it's true because of that human tendency to believe things that you want to be true?
It's a great question. I will say, so one of these like Vivos providers I messaged on Instagram and she blocked me. So that screams to me, hey, I don't want to talk to you because like I'm a scam artist, right? That's how I take that. Whereas Truth, even though we didn't agree, he wrote back to me like we had a long conversation. So, and I think he actually truly believed in it because it helped himself. But as I said, it helped himself because there's certain benefits to the DNA that actually are true, but it doesn't change your DNA and do all these crazy things that it says.
Yeah. The naming of the appliance is interesting. It's like one is the DNA and one is the RNA, right?
Yeah.
Is that meant to hint back at like some sort of effect on the genome and like triggering some sort of genetic change or epigenetic change in the patient that turns on growth centers?
Yeah, exactly. 100%. Well, why else are they doing that?
I don't know. I mean, I don't know. Naming can be arbitrary, but
it's called the daytime nighttime appliance. That's what it stands for, DNA.
Oh, that's what it stands for.
Yeah.
Okay, that would make more sense.
But
because it's worn daytime and nighttime. It has nothing to do with, deoxyribonucleic acid.
Correct.
Okay. All right. That's fine then.
But
it's just a coincidence.
And then they have the mRNA, which stands for repositioning nighttime appliance. I'm looking this all up right now. So
really?
Does it stand for that stuff? No, but come on, Ron. They're obviously hinting at something.
I mean,
look, I'm looking at here, someone right now. It says, Smile Angels of Beverly Hills. The appliance provides gentle physical stimuli to the teeth and bone. This stimulus aims to wake up dormant cells in the craniofacial region. That's
someone's current ad on their website?
Yeah.
Live July 1st, 2026?
Yeah.
For adults?
For adults.
Wow.
You don't look, I can show it right now. You don't want to go down this rabbit hole, man. I used to like get
Oh,
so
I've
upset
been
by
down this
this.
rabbit hole, man. I've been down this rabbit hole.
Look, naturally expanding the palate in adults, the science of epigenetics and orthodontics.
Is this person an orthodontist?
No way.
Okay, but they're still allowed to reference orthodontics. They're
Yeah,
just not. They're just can't say I'm an orthodontic. I'm an orthodontist.
correct. By the way, I have no idea who this person is. I've never met them. I've never seen this website before. Does he say no? Yeah,
Hmm.
says he actually has a TMJ. Interesting.
Seems like a nice
But
guy.
yes, I'm seems like a great guy. But yeah, epigenet. You see it right here. Signs of epigenetics and orthodontics. These
Wow.
cells have the potential to create new bone. Wake up. So
Hmm.
I don't know.
Hmm. Yeah.
Yeah.
Well, I guess you know, we should do some CBCT superimpositions of some of the patients that have been through it so we can see the new bone. Wouldn't that show
Yeah.
one way
So
or the other?
yeah,
Have you ever seen those?
Truth sent me some, and
What'd
I
you
didn't
see?
nothing.
Did he not superimpose them like
No, he
precisely?
just sent me screenshots, but I did the measurements. Like there's nothing there. I mean, you had dental movement, which is great. As I said, the dental movement alone is enough for some people.
Yeah.
The
Yeah.
appliance itself alone is enough for some people because you're disarticulating the teeth, and that helps so much. That's why some people, when they do Invisalign, they're like, "Oh my," it actually helps them because their jaw pain goes away because they're just disarticulating the teeth.
Yeah.
That's a huge thing.
Yeah.
Um,
You think I should talk to Truth? Should I bring Truth on and ask him some tough questions?
go for it.
What
He'll,
would
he'll
you ask him if you
he'll
were me?
he'll talk to you. I mean, he was at Alfie's conference. Um, as I said, truth. He's looking for the truth. So he
He is?
gets. Yeah,
That's sincere?
I think it's sincere.
Okay, if that's sincere,
Uh,
then I'm game. That's all I'm doing. That's all you're doing, right?
yeah. And I think in the beginning he said some things that were more like trying to get, just like TikTok
Rage
trying
bait.
to get, yeah, rage
Rage
bait.
bait.
But we
We're all
actually did,
guilty of that.
yeah. But I think in the end I think he actually, is trying, but it's it, it's he's willing to talk, and I really do
Okay.
appreciate that.
Yeah.
As I said, a lot of these other people, you start questioning them, and they just go silent on you.
Well, it's like politics, right? It's like you can have people on the other side of the aisle from you, and that's fine. And
Yeah,
that's essential for the political system to have a diversity of views, but you have to be willing to talk and hash it out using the powers of reason that are
yeah,
inherent to the human animal. Like that's what we do
yeah,
is we reason and we can
correct.
talk things through and make arguments and may the best argument win, right?
Yeah,
But if you just take on your beliefs as an identity, and if anyone who's trying to, force you to defend your belief system causes you to go into a defensive where you shut down and you
mhm,
become hostile and you start calling them the bad guy and the
yeah,
enemy, well, then that's kind of like the story of American politics right now. That's not healthy.
correct. It's not. That's why
So,
I really do appreciate that he talks and he's willing to discourse, and so I really respect him for that.
yeah.
And yeah, we've been talking about some cases and stuff too, so it's cool.
Oh,
And
cool.
we're like, I know we're kind of like he's like my what's it called? Like my nemesis, we say. He's like my
He
TikTok
is.
nemesis. But it's good conversation.
Do you ever
Um,
knock him for just being a general dentist, or would that be considered a low blow?
no, I would never do that.
Oh, okay.
Um, I yeah, the general dentist thing,
Yeah. What do you have to say about that?
I it's funny. So first off, I think people should do whatever they like, right? Like if you're a general dentist and you really like doing Invisalign, then do it, right? But you should be able to, give the patients all the options, right? And as we're saying, MARPE, jaw surgery, these are all treatment modalities that if you're not comfortable doing, you just have to give the patient, the, option,
Yeah.
Um, look, there's bad orthodontists, there's bad general dentists. So I will say too, for general dentists, like they're doing cavities, crowns, all this other stuff. And so you really have to think to yourself, like if you truly love doing it, because some of these cases, if you don't choose the right case, right? If you're not doing like an easy crowding case, and let's say you're trying to do bite correction or something like that, that takes a lot of visits. And so it might not actually make financial sense for you once you've done a certain number of visits. And so you really have to think about that. Because either once you go past that point of, oh my God, I have all these visits, I'm not making any money, then you better be doing it because you love it.
Yeah. Yeah, because an orthodontics practice has a whole supporting crew around it. You have assistants that are also trained in orthodontics assisting and who can actually place braces and
Exactly.
you go in and you tell them the adjustment to make and they can actually do it. And a general dentist would need to create that infrastructure.
Correct. So yeah, you'd have to have basically like a mini orthodontic practice in order to support that. Because most orthodontists, right, I only have 2-3 chairs, but most orthodontists have like 5-6 chairs. So if a patient comes, let's say they come 3 or 4 more times than they were supposed to, it's not a big deal to you, right?
Yeah.
But for a general dentist, that could be a huge waste of time because now they're taking up your one chair and you have to do the scan, you have to talk to them, and it becomes a whole thing. So yeah, I try to help my general dentist colleagues. I obviously like general dentists. My brother and my dad are general dentists. I have a lot of respect for them. And yeah, I just it is funny, like people will ask me for advice and I'll tell them, I'm like, yeah, like this is not a good case to do. And they're like, okay, I'm gonna try it anyways.
6 months later, Dr. Luke, you were right. No, I mean, we have to give general dentists credit where credit is due. I am not sure that airway dentistry or airway orthodontics would be where they are if it wasn't for general dentists sort of creating a massive push in the late 2010s in the direction of so-called TMJ dentistry. And even though a lot of them were using tooth-borne expanders, the idea that you wanted to make things bigger rather than smaller, and like that you wanted dentistry to be the profession that actually takes ownership of airway. Like, I don't know if orthodontics was too kind of much resting on its laurels and its, see 50 patients a day, roll in gravy workflow to actually stop and consider pivoting toward airway. But general dentists maybe are the ones that hated drilling and filling enough to look for some other way they could contribute, right?
Maybe.
So, I don't know, do you think that this space would be where it's at if it wasn't for the big push that general dentists seem to have made, 10 years ago?
No, I think it's everyone. Everyone, oral surgeons have orthodontic surgery. I mean, look, the general dentists, they're the gatekeepers, right? And so they're the ones that have seen their patients, twice a year for many, many years. And, they've established these awesome relationships with their patients and they can really tell them like, hey, you should do this. So ultimately, a lot of it does come down to them. But I do think like all the professions all the specialties in general dentists have helped in their own ways. I don't know, maybe the general dentist did the most. I don't know. I honestly never really thought about that.
Well, it seems like orthodontists didn't get too involved until MARPE became available, because otherwise they would have only had like tooth-borne expanders as like a really powerful tools to actually affect anything. And though like orthodontists would have been generally opposed to tooth-borne expanders being used too aggressively, whereas general dentists were, for lack of better terms, ignorant enough to actually like push those appliances really far until MARPE became available. And then everyone was like, oh, we want that much expansion? We can actually do that with this. And that's when orthodontists and MARPE sort of entered onto the scene. So it almost does seem like a historical idiosyncrasy of how the space developed, where it sort of depended on the general dentist tooth-borne expansion phase to create a market of patients that were seeking airway intervention that then orthodontists and skeletal expanders and jaw surgery ended up actually being a safe solution to that trumped up industry of people that actually wanted to make their jaws bigger.
Yeah, it's possible.
I mean, that was my trajectory. Desire to make the jaws bigger. Only really so-called airway TMJ dentists willing to take it on, because the orthodontists at that time, I think, were just saying, my jaw surgery, which for newcomers to the space is very daunting. Then you realize the tooth-borne expanders are trash, and then you move on to MARPE when MARPE comes on in 2018, 2019.
Yeah, and I think too, like orthodontics, like historically, we've just been, we just want to straighten teeth, right?
Yeah. Right.
And so if you think like what percent of people would you say have sleep and area issues, right?
Oh God, yeah, that's a tough one. But
let's say like 10%, 20%. I don't know. So I'd say the most patients in an orthodontic office like don't have, airway issues, and they just want to straighten their teeth and whatnot. So we become more like orthodontics over the years has been more of like a cosmetic and functional specialty, right? Now we're finally starting to do more airway and everything. But I also think too, like airway kind of went hand in hand with it, right? Like if you had a recessed jaw, we would do jaw surgery to make your bite and your jaw better. And so we were having a lot of airway benefits from our treatment without even realizing it.
Yeah.
But now, it's it'll be interesting to see, right, where we are in 5-10 years. With everything.
FME 15, obviously.
Yeah. Why not 16?
It could be. Well, because they might do like a FME like 7S instead of going to 8. They do like an S iteration like the iPhone.
Oh, wait, what number are they at now?
Pro.
So it's just
FME Pro.
What was the original one called?
Well, the first one that had any amount of notoriety was 3.5.
Okay.
Although I think Dr. Ting's FME, the one that he had that failed, might have been an even earlier version, but I don't even know what its name would have been. Maybe 3 or 2.5. We're at 4.5 and Pro now, which I think they should have called Pro 4.5 Pro.
Okay.
They just seem to be following the iPhone, the Apple naming convention. I don't know.
Look,
I'm kind of being a smart ass, but
Apple's $1 trillion company. They have it right.
Yeah, Apple's dope.
I would say
you're a big Apple guy.
I mean, I'm talking to you on a PC, but I like Apple.
Okay.
Apple stock. Apple
iPhone. Hope you're not trying to buy a Mac Studio these days.
No.
They're tough to get.
No. Basically, like, I have a PC because the EHR system I use like only works on PC.
Yeah.
And I bought the practice, and so it's like too hard to convert it somewhere else.
Yeah.
But maybe with AI, like in a couple of years, I'll be able to transfer the data more easily, and it'll be fine. But who knows? So for now, I'm stuck with a PC and Dolphin.
Yeah.
So
that's awesome.
So,
yeah, I did want to ask you another question, but it's pretty involved, so I guess maybe we'll save it. I wanted to ask you about jaw surgery setup, and like I'm trying to establish mental boundaries on like what is actually involved in pre-surgical ortho, trying to understand the different species of decompensation and like how different cases are set up, how class 3s are set up, how class 2s are set up, like, how MARPE patients are set up.
Yeah.
But I think that's probably like a 1-hour discussion in and of itself.
I give you like a quick answer. I said the most important thing is the tripod. Okay. When we get these models, right, we print them out. This person, right, she's a class 3. So when we move her into the desired position, I need the bite to be stable. Okay. If it's not stable, then the surgeon can't put them into position. So that's the most important part. From that, right, it doesn't, whether we move the jaw like that or like that or like that, as long as the teeth are together, that's like what the surgeon really needs, and then they can, kind of make everything else work. Now, in terms of decompensation and whatnot, that just kind of refers to being able to get to that stable occlusion. Because basically, how can I put this? If let's say, for example, basically what happens, let me see if I can show you something. Let's take a class 2, for example, right? They're usually compensated. So their upper incisors are lingually inclined and their lower incisors are proclined, right? And so there's nowhere to actually move. So let me show you.
Yeah, because the teeth are creating interferences. Would you call them interferences, or does interference only apply when you're talking bone on bone during jaw surgery? I don't know.
Yeah, let me show you this person here.
Yeah.
How do I do this? Okay, let me share my screen. Okay. So this right here is the perfect example of a class 2 compensated individual, right? Can you see that? You see how the incisors?
Yeah. Uppers are tipped in, lowers tipped out.
Correct. So if we were to do jaw surgery like this, you can only move everything forward with them in this position, right? But let's say, and if we look at the molars too, right? They're in class 2. But now let's say we bring those.
How do you identify a class 2 molar relation? What are you looking at?
Let me show you here. So like if you look here, you see how the cusp.
You look at the second molar. I'm sorry, you look at the first molar.
Yeah, so this cusp tip, the mesial cusp tip of the first molar should be in the groove right here. You see that?
Oh.
So this person's like.
So the lower jaw is too far back.
Correct. This person's an end on. And now check out this too. Remember what I said about, did I say this? Genioplasty. Most patients that have a genioplasty really need a double jaw surgery.
Is that a non-bony? Is that a non-bony genioplasty?
Yeah, it's just an implant.
It's a silicone implant or something?
Yeah, exactly.
Oh. I was going to say, because the profile looks decent.
Yeah, the profile looks decent because of the implant. Most patients
genios are so powerful sometimes, aren't they?
Yeah, I mean, in terms of the aesthetics, she looks great, but it didn't address the underlying issue. And then this, you see how these incisors are super upright? If you look, this says they're at 86. If you look here, we want them usually to be between 98 and 108. So they're about 10 degrees under torqued. So in a class 2, what we're doing is we want to upright these incisors so that they're like around 90 to 95. And we want to torque out these upper incisors so that they're around 105.
So you'd make the class 2 temporarily worse.
Correct.
And then you can get a bigger sagittal split advancement.
Correct.
Yeah.
Because if you just moved everything like this now, you'd still be in a class 2 relationship, and then you can't get the lower jaw to come forward as much. And then you'd have to move the upper jaw really far forward, but then it looks weird because they have like a big upper lip. And then also when you move the maxilla forward a lot, then you also get, you get like the nose upturned. And so there's all these different things to consider.
Yeah. Yeah.
So let me see, do I have, I thought I took new pictures, but I didn't.
What about setting up a segmental? Have you ever done a jaw surgery with Dr. Gunson? Have you ever set up a Gunson segmental by any chance?
No, I wish.
Do you have? Why do you say that?
No, he's a legend.
Yeah.
Him and Arnett.
Yeah, Arnett for sure.
The practice I worked at before, they had a couple of Gunson cases, but I can't like remember them specifically, and I don't think they were segmental.
Okay. Well, do you have any surgeon that you work with who's extremely particular about his pre-surgical ortho? And you could please call me out if I'm full of shit here, but it seems to me like there's two types of surgeons. There's surgeons that are kind of lackadaisical about pre-surgical ortho, and they're like, the ortho will kind of put it back together after. And then there's surgeons that are meticulous pre-surgical, and I've seen Gunson cancel a surgery because the pre-surgical ortho wasn't quite where he wanted it.
I mean, that's crazy. But I would say, like, I'll show you this here. Let me show you, just so you know. So check this out here. This person had surgery first and they came to me like this, right? And you look at the VSP, everything looks fine on the VSP, right? Like there was no open bite like this. Look how
Okay.
look how quickly, this is 1 month.
Is that because of wrap phenomena?
Wrap phenomena, I think, and look at that, now we're done. It took 6 months.
Wow. Braces or Invisalign?
No,
or?
Invisalign. That's it.
What, do you change the trays out every 3 days after jaw surgery?
Every week. Yeah. But isn't that crazy? Like, I think it's a combination of the wrap phenomenon and then just like posturing and lots of things going on. But yeah, you can recover pretty quickly after jaw surgery. That's why I've had cases where I send the occlusion is perfect, and they come back with an open bite. And then I have patients where my occlusion is terrible and they come back good. So who knows? Who knows?
No, but you need to know. What do you mean who knows? You can't operate on a who knows.
Who knows?
Who knows is not a strategy.
Who knows what's happening in the operating room?
I understand that, but yeah. No, you got to know. You don't want a who knows surgeon.
But my point is like, even if the bite doesn't come back perfectly, we're usually able to get in a pretty good position as long as the condyle is well seated, aesthetics are good, whatnot. Like the teeth being that open, I'm not worried about.
Got it. But it's also not. So people will actually plan to have that level of malocclusion after a surgery, and they'll just be like, "All right, Dr. Shapiro, it's on you."
No, of course, that's what I'm saying. It's not planned. They just come back to me like that.
Is the change, is the delta between the VSP and what you're actually seeing occurring in the days and weeks subsequent to the surgery because of drift, or is the surgeon just not? Is the surgeon just fucking up the plan?
I wouldn't say fucking up because it's complex.
Yeah.
I think, as I said, I think it's a combination of a lot of different things. But my point is, it's not a big deal because we're usually able to recover within a certain amount.
Yeah.
And I've had friends recover from even worse than that. I wouldn't even call it recovery. It's just normal. It just happens.
Yeah.
I mean, look, sometimes it comes back perfectly, but I don't know. I wish I had an answer exactly why it happens, but I think it's a combination of everything, as I said.
Yeah. Do you find that happens less with totally custom upper and lower jaw surgery?
No, still happens then.
Still happens?
Yeah.
How do you explain that?
But it's not a big deal. That's what I'm saying. I think, as I said, I think it happens because partially the teeth shift a little bit, partially the condyle is not perfectly seated. Yeah.
Right. The seating of the condyle would explain a lot. Because
partially.
if the lower jaw repositions away from where the surgeon intended it, then you can instantly get multi-millimeter change, right?
Yeah, but how would you explain that? Like after a month or two, I'm mostly always able to get these patients back into like, they go from like, let's say they go from like 20% the bite to like 90%. How does that happen so quickly?
I don't know. I mean,
I don't know.
You think it's what?
No, I think it's the condyle seating. I think there's some wiggle room in there. I don't know. You got to get a surgeon on here to talk about it.
Yeah. Well, surgeons, I feel like they don't really like to talk about their own cases ending up open like that. I feel like surgeons want to give the impression that everyone comes out of surgery with a perfect bite. Isn't that considered an ideal?
I mean, I'd love that, but it's never really happened.
Yeah.
Uh, yeah, there's always like a
Because
little bit
be,
off.
because like isn't it the case as well that with say a segmental maxilla, you don't want to do too much orthodontics because the segments are sensitive and you don't want to put too much force into them? Or
And so to
is
be
that a
honest, I
myth?
haven't done segmental since residency. I'm gonna be completely honest. I had a couple segmental cases at my old practice. Like I saw it happen, but I wasn't like, the main orthodontist on that. Um, Segmental is different because it's so much more difficult because now you have to be in like a splint or something for multiple weeks because or else everything would move, right? Um, so the segmental is also like more prone to relapse, right? Like the transversely.
Hmm.
Um, and you can only expand a certain amount with segmental.
Interesting. Interesting. Well, so Gunson, I have a client of mine who had a segmental with Gunson a few months ago
Yeah.
and did not have a splint at
And
all. There
how'd
was
it
no
go?
splint and it went fine. And
Good.
so I think then is the explanation for why Gunson is so meticulous about his pre-surgical ortho is the fact that he's not using a splint and the bite is what stabilizes the segmental.
That would make sense. Yeah. I think that's possible.
Hmm.
Was it a big segmental?
No,
No. That also
no,
that also helps too,
yeah,
right? Like the bigger the movement, then the more difficult it is to maintain it.
right.
Um, but that's awesome. And the occlusion stayed perfect. Like you'd say like it was from the BSP to that.
Thus far, yeah,
Wow. Uh, that's nice.
yeah. So, but then that would indicate a workflow with Gunson that is a lot tighter then. And I hesitate to put too much value on this to suggest, oh, his way is great, everyone else's way sucks, or something like that. But it does suggest that, like, he has a much lower tolerance for what he wants the bite to look like coming out of the OR and in the weeks after, that he somehow is imposing more control over that.
Yeah,
Does that seem to be the case?
that's possible.
Yeah.
But as I said, even I've had patients with perfect bites, and like they were surgery first, right? Their bite was perfect. They just
Mm.
wanted to move everything forward, and there were still issues. So
Mm.
that's why I think occlusion is important, but also it's not the end all.
Yeah.
Um, does that make sense? Right?
Yeah.
Like
Yeah.
that's when I was like that's when I realized I was like, okay, something's up because I have these patients, they're perfect class one occlusion, and they're getting, an advancement for sleep apnea, and they still end up open. What's happening?
Hmm.
I don't know. I'm not a surgeon.
Yeah. Yeah. Well,
So
I also know Gunson is very particular about finding centric relation of the joint prior to surgery. Like when you go in to see him for
yeah,
your workup, he does a lot to try to relax your mandible into a centric joint relationship. And so maybe he's really building around that because if
yeah,
he feels like if he can impose more control over the condyle and the joint, that that's also going to contribute to minimal malocclusion post surgery because he's
yeah.
maybe getting that closer to ideal.
I think that's a great point. I think like even if you go to yourself right now, right, like, and you can kind of feel your CRCO shift, right? It's kind of hard to find. Like there's still, there's some wiggle room, and so I think finding the exact bite combined with the condylar position, I think is really important. And I think that would probably explain most of the discrepancy that we're seeing.
Yeah, interesting. All right, yeah, this you're getting my juices flowing for when I go see Dr. Sullivan in a couple weeks. I'll be
Good.
asking him these. I'll actually be shadowing him in the OR. So,
But also too, like I don't know how much they can tell you, right? Like I don't know if it's like a such an easy thing. It's like, oh, this is how you know, right? I don't know.
Yeah. Yeah.
But I'd be very interested to hear all that, and that's gonna be cool that you get the shout in the OR. That's
Yeah.
amazing.
I know. I know. Yeah, I
Uh,
know. I feel very fortunate because I know Dr. Sullivan he's definitely a unicorn, you know. He's the surgeon. He's
is
not very well known, but
is he gonna let you put the condyle in place? Hopefully.
oh man. I not if he's smart, which I
Okay.
think he is. So, but no, I'll be definitely at a safe distance away.
Okay.
That'd be in a different lifetime.
Yeah. Did that answer help you, by the way, with the when you're asking me?
Yeah, yeah,
Okay.
no, for sure, for sure. Yeah, I feel like this is really the direction I want to go more in, is to understand workflows, because I feel like there's a lot of answers and wisdom in understanding workflows,
Hmm.
and especially around the relationship between the orthodontist and the surgeon. And it's definitely something I need to understand better. And where I know we're coming up on time, and I'll let you go here in a minute.
Yeah.
But we can maybe pick up on that another time too. But it's definitely some good food for thought for now.
Yeah. No, always happy to chat. Get my number now. Um, and yeah, I think just keep looking at cases, different experiences, and you'll keep learning and figuring out what's best and what works and what doesn't work.
Sweet, sweet. Oh, and I always ask my podcast guests, would you be willing to come into the Joint, my member site, to do a informational Q&A, live Q&A with my members at some point soon?
Yeah, of course. What is it like it's like a live type thing, like a
Yeah, it's a Zoom call where people raise their hand, and then they
yeah.
basically come on in the order that they raise their hand, and then they ask you questions.
Yeah, cool. Sounds fun.
Yeah, it is. It's a really good group. It's really high level stuff.
How many
Like
people are there about?
on any one call, there might be somewhere between 15 and 30 people.
Wow,
Yeah,
that's cool. Yeah, happy to
yeah.
do that.
It's really fun. It's like a live interactive Reddit forum.
Yeah. It reminds me of the the New York Airway Club, and it gets very interactive. If you're in New York next time, we have it once a quarter. Um, so yeah, there's some good discussions there. People are just like shooting out questions left and right.
Oh,
So
sweet. Yeah, that sounds dope.
perfect.
All right, Dr. Shapiro, thanks for joining me on the JawHacks podcast.
Yeah,
Appreciate
thank
your
you.
time. And all your links will be in the description. You're in New York City. If anyone wants to find you, that's where you'll be. And we will catch up again soon, okay?
Awesome. Thanks, Ron. Thanks for having me, and talk to you soon.
All right, thanks a lot, Doc. Bye-bye.
Thanks. Bye.